Hi, everyone. Good afternoon. I'm Dr. Hong Guanyu from the Taipei Medical University, and I will quickly go to show my case. There are three parts of my talk. The first, I would like to introduce a case, and then I will show you how we treated this patient based on the evidence-based approach. And in the next couple of minutes, I would like to have dialogue and discussion with you about how to manage this patient. And first, I would like to thank Eli Lilly and Baringer Ingelheim for inviting me as a speaker to share with you this case, this patient, and this is my disclosure. Let's go to the patient. It's a middle-aged male patient. He was referred to my clinic for the bilateral lower leg extremity edema, and I reviewed his medical history. He got the diabetes, a cardiac problem, and hyperlipidemia, and also he still have the smoking for many years. And for this patient, the first step is to try to differentiate the potential causes for the leg edema. So physically, I noticed that he had the blood pressure is higher than 140, and there is no clues about the cardiac problem or the liver disease. So the main focus could be the renal issues. So the laboratory test indicated that yes, the patient okay, now I can see. The patient have a slightly renal decline and the hypoalbumin in the serum and the borderline hyperkalemia. And yes, the patient had a poor control of the diabetes. So if we summarize the current clues for this patient, we have an idea that the patient have been intermittent leg edema for almost 1 year, and he got many underlying diseases. The current presentation for the patient is the picture like a nephrotic syndrome and the borderline renal decline and the poor diabetes control. So I would like to raise my first question. If for this patient, he was referred to your clinic, if they are following, we have 5 items, but if you can only choose one. First, which one is your first priority to identify the renal risk and the renal status? What would you do? You may check the more correct urine for the more informations, and you can check the protein creatinine ratio or the albumin creatinine ratio. And of course, some of you might go directly to renal biopsy to confirm if the patient was a diabetic glomerulonephropathy or the other etiology. So what's your choice? Before we go to the direct answers, so I would like to show the risk of renal status. We know that the diabetes, there is a period called the silent period. The silent period means that long before we got the full presentation of the patient, for example, this patient had the leg edema or the renal decline, long term before that, there are some clues or the early signs. So what is the first sign or the early sign of renal failure or renal involvement in the diabetes population? The first sign is the proteinuria. So the proteinuria will develop long-term before or many years or more than 5 years ago, more longer than the full spectrum of leg edema. And in addition, that there are many cohort studies to tell us that the patient, if the patient have the higher urine protein level or the poor renal status, will have the poor renal outcome and the heart outcome as well. So the important is to have the clear identification about the renal risk and the renal status. So let's go back to the selecting items. So which one will you choose for this patient? I will choose the urine ACR, to check these patients. Why not the urine PCR? I know that some of you may have the idea, or we have the ideas from the different clinical specialty that urine ACR and urine PCR seems like the same. There is a fixed ratio around 5.5 between these two items. So some may say that these 2 items are not quite different. But if we try to make it clear that from as I show you here, that is the information coming from the Harrison's textbook. So in the checked ACR and PCR, there is indeed a difference between these two. It's for the decision making. For example, for the proteinuria, yes, the proteinuria and the microalbuminuria both are the indicators for the signs of cardiovascular morbidity and mortality. And for the ACR is mostly recommended for the diabetes population. But for the PCR, it's a little bit different. It means that basically, or from the pathophysiology, that PCR means the protein loss from the kidney, which may reflect that the renal disease is the underlying problem. So to choose ACR or PCR, it's a little bit different. If for the patient, most of our concern is about the protein level, especially the albumin loss. For example, in the diabetes patient, we might prefer the ACR first. But if for the patient with the multiple sources, multiple resources from the protein loss, we might choose the PCR level. For example, in patients with primary nephrotic syndrome, for the preeclampsia, and for the multiple myeloma. So for this patient, I will select and I will arrange for the check the urine ACR. And it was supported by the 2 articles published in the Kidney International 2 years ago. You may scan the QR code here to download the full article. You can see that these 2 papers are published in sequential in the same issue. It's a consensus coming from the ADA and the KDIGO to tell the colleagues and the medical physicians how to taking care of the patient with both disease, the diabetes and kidney disease. And Professor Hong has shown from Korea has shown this slide. The information here is quite clear that for this patient, if we like to screen for the renal issues, we might use the ACR and the EGFR together. And how to define that the person or the patient have the CKD disease. There are 3 conditions. The patients who have the measurable the protein loss, have the renal decline, and most importantly, has the other evidence of kidney damage as well. And if the patient have been diagnosed as the diabetes and the CKD, so the next step is to initiate the adequate treatment. So what is the adequate treatment? The adequate treatment is evidence-based treatment. So let's go back to the indicated case. Now we have the better idea that the patient, the follow-up laboratory testing reveals that the patient indeed have the protein loss and the hyperlipidemia. So it's a picture of diabetes, poor glucose control, poor diabetes control, and borderline renal decline, and the nephrotic syndrome and hyperlipidemia. And of course, the blood pressure still a little bit higher than our standards. And these are the current medication for the patients. We will discuss that about later. So now let's go to the treatment. Here are the current medications for this patient. Yes, most of you have noticed that the patient did not reach the therapeutic goal. As I show you, that the blood pressure is still high, the HbA1c is more than 9%, and they have moderate to heavy proteinuria, and they clinically have nephrotic syndrome. So what we can do to improve the nephrotic syndrome, or can we have a chance to slow down his renal progression? If we refer to the therapeutic goal that mentioned in the textbook, and which was reviewed in around many years ago in the AJM, that this is not a new idea, but it's just a review to remind us that the therapeutic goal is quite clear, but not everyone, or most of the patients did not reach the therapeutic goal. For example, the patient still smoking. Yes, he received the ARB for the blood pressure control. We have no data if the patient adhere to the low protein diet, but the LDL level, HbA1c, and blood pressure, this indicated he did not reach this therapeutic goal. Actually, this is not a very new idea. This idea has been launched for almost 30 years, and most of the patients did not reach the therapeutic goal, which means that we still need a long way to go to have more adherence or to education the patient to have adherence to these guidelines. So if for the ARB, we know that as far as I know, that there are only 2 kinds of ARB that have the large-scale clinical trial, the RENAIL study and the IDN study, to indicate that the losartan and irbesartan could have the renal protection, not only in the reduction of albuminuria, but also can have a better renal outcome. So the patient now, he is used on the losartan, and at present, it still remains not well studied that losartan have the large-scale clinical outcome to indicate that it can protect the kidney. Of course, it can reduce albuminuria, and in the small scale clinical trials, for example, the ABCD trial published in 2006 or the MARBLE trial in 2002, both studies have the small scale study, and they follow up for the albuminuria reduction that the losartan could have the benefit. But for the renal outcome, we still need more data. So some of you may believe that we have a class effect on the different kinds of clinical agent, but actually we still need more clinical trials like the MPAR kidney to have more solid renal outcome to convince that this agent is the good choice for our patients. So if we want to shift from the therapeutic goal-based study or the management to the standard therapy to have more organ protection, we still need more medications like the SGLT2 or the other medication that Professor Hong from Korea just mentioned about. I'll show you two slides here. These are a briefing from the KDIGO guideline, which was published this year, that for the patient who have the chronic kidney disease, our patient is like here. Our patient, the borderline eGFR level around 45 and the heavy proteinuria. So this is our patient who is the status here. For this patient, if we like to have the more clinical trial-based, the evidence-based study for the patient, the MPAR kidney, the Jardiance could be a very good one. So this is the summary from the KDIGO guideline that the SGLT2 inhibitors is recommended for patients with type 2 diabetes and the patient with heavy proteinuria. And there's a strong evidence that the SGLT2 inhibitor could have a better renal protection than the other agent. Of course, it's based on the adequate ARB of ACE/RAS inhibitors. And Professor Yang has just shown you this slide also before, that now the SGLT2 inhibitors, such as the Jardiance, has been listed as the first-line agent for the patient, for the diabetes control, for the renal protection, and for the heart protections. And it is based on many landmark trials or milestone studies to indicate that the patient with heart disease or the renal disease could have a benefit from the Jardiance. So I still have a couple minutes before I move or end into my talk. I would like to show some time to discuss about how to manage these patients. First, I would like to talk about the medications. So as I show you in this slide, that these patients have the current medications. So what's your treatment plan for the patient in addition to the SGLT2 inhibitors? Let me summarize what I just showed you, that for the patients, we should have the patient to stick to the therapeutic goal first, and the others, we may choose the right agent for the patient. The patient have the poor diabetes control, so we will add on the SGLT2 inhibitors. But as far as I know, that the single agent, any one single agent could not change everything. So we still need to have a holistic care for these patients. So if I listed all the medications here, I will try to raise the first question about the metformin. Will you keep the metformin use in such a patient with the eGFR around 45? Or the serum creatine levels 1.8 milligram per deciliter? Or you will stop the metformin and add on the SGLT2 inhibitor, or try to start the basal insulin or GLP-1 receptor agonist, as mentioned by the Professor Hong from Korea. So do we have the guideline-based recommendations? If we check the KDIGO guideline published this year, the metformin still could be used in the patient if the patient has EGFR of 45 or further or higher. And if the patient was lower, if before the guidelines, we know that when the patient has the serum creatine levels more than 2 deciliters, higher than 2 deciliters per milligram per deciliter, we will not be recommended to use the metformin. They should stop the metformin use. But in this guideline, it mentioned that metformin still could be used, but we need a more closely monitor about the eGFR, the change of the patient. And this is more clear information shown here that metformin still could be used in this indicated patient. But if we add on the SGLT inhibitors, if the patient still have poor diabetes control, we may consider the GLP-1 or the other indicated agent, for example, the basal insulin. And as the Professor Hong from Korea showed that the FLOW trial just recently published, that it could have the better outcome for the kidney and the heart protection as well. So in this patient, we may keep on the metformin and have a closely monitor. And if he still have the poor diabetes control, even we have the lifestyle modifications and more education for exercise and stop smoking, then he still have the poor diabetes control, we may consider the GLP-1 receptor antagonist for this patient. So how about the blood pressure? Now the patient still have the higher blood pressure, more than 140. If we refer to the SPRINT trial, which published several years ago, it's a study more focused on the CKD patients. The conclusion was if the patient have more intense treatment for the blood pressure control to have the therapeutic goal of 120, it will have the more benefit than the patient with the blood pressure still remain on around 140. But the measurement of the blood pressure is different. It's from the home-based measurement, not the office measure the blood pressure. So if for the patient, what's your next step? You will try to titrate up the dosage amlodipine or the valsartan, or you may just shift the valsartan to other more clinical-based, evidence-based ARB, like the losartan or irbesartan, because these two agents, based on the RENAIL trial and IDNT trial, they could have the more promising renal protections. Will you believe there is a class effect of the ARB, or you will shift, keep on the valsartan? You may still have the other option to add on the non-steroid or MRA, for example, the finerenone. The beneficial effect of finerenone have been mentioned by Professor Hong from Korea, that it could have the anti-fibrosis, anti-inflammation, and additional benefit for renal protection. Of course, the potential hyperkalemia could be a potential concern. So what do we do to treat this patient? And what's your therapeutic goal for the population levels? The 120 or 140? That we may still have the room for discussion. And I would like to hear what's your opinions. And if we search for the KDIGO guideline for what's the recommendation is that not everyone should stick to the intense blood pressure lowering therapies. For patients, they have the symptomatic concern, or the more aging patients, or the patient have the symptomatic postural hypertension. Not everyone is absolutely recommended to have the intense blood pressure control. You may have set a higher level than this one. And of course, how the blood pressure was measured by the home, it's a home-based measurement or office-based. That's not the same. And the last but not least is the hyperkalemia. For the hyperkalemia, can we add on the non-steroidal MRA? Yeah, or if we titrate up the dosage of valsartan, is there any challenge or risk that it will increase the level of hyperkalemia? That's also a potential concern. This is a paper just published last week in the BMJ that indicated that if you use the SLT2 inhibitors or GLP-1, that will compare with the DPP-4 inhibitors only, could have a low risk of hyperkalemia. And the conclusion of this paper is that in addition to improving the both heart and kidney outcomes, the SGLT inhibitors and the GLP-1s could have the more potential benefit in the patient if the patient have the risk of hyperkalemia. So before ending of my talk, to sum up, I would like to thank all of you to join us, to stay with me to discuss of this case. And this is a typical case that we usually see in our daily practice. The patient have multiple underlying diseases, has heart problems, had the hypertension, and have a poor diabetes control. And the first we can give the advice to a patient is the lifestyle modification, education, and exercise, stop smoking. Then the more detail is how we make the recommendation for the agents or drug that is now currently used. And will we use the more appropriate agent for the diabetes control or for the blood pressure control? So it needs have this case and show us that we still have a long way to go, and we can have more discussion. And thank you again for joining with us. Thank you.
Thank you, Chairman, for your nice introduction. Can you see my slide?
Yes, very clearly.
Okay, it's a great honor for me to have this presentation in this wonderful symposium, and I'd like to share 3 cases. These are my contents. First, it is related to elderly diabetes with DKD and heart failure, and second one is young onset diabetes with complications, and the last one will be diabetes with fatty liver disease. First, the cases shown here, like 70-year-old man with obesity, BMI 626, and he has been diagnosed with diabetes for 16 years. And you can see he has GFR of 63, and he has macroalbuminuria over 300. And also a couple of, like 2 years ago, he has been diagnosed with coronary artery disease. And also you can see from the echocardiogram, EF50 and proBNP levels are like 1,900, which means like he has HFpEF. And he was currently treated with metformin and zemigliptin, which is a DPP-4 inhibitor in Korea, and sulfonylurea. And he was referred to my clinic to use other medication that helps to control his glucose levels. So you can see these are like typical long duration of diabetes with multiple complications such as nephropathy, and he also had neuropathy, and also he was diagnosed with like macrovascular complications as well. So these days, like you can use SGLT2 inhibitors because there is a compelling indication for heart failure and CKD. And like 2 years ago, he came to our clinic, and initial like HbA1c was like 6.8 and GFR 63. And after like 3 months later, I decided to use empagliflozin, changing from DPP4 inhibitor to to control his proteinuria, and also we wanted to use this SGLT2 inhibitor to control heart failure as well. So at the time when I introduced empagliflozin to him, the GFR was like 56 under 60, like CKD stage 3. And after 3 months later, using SGLT2 inhibitors, hopefully like his GFR was maintained like 56 to 59. And also, I didn't check like 3 months earlier, but according to like 6 months earlier, albuminuria level was like over 600, which came to like 270, which is much improved after using SGLT2 inhibitors. And also, when I checked NT-proBNP levels, which was initially like 1,900, this level also went down by almost 50% decrease, like around 1,000. So after that, I continued using the same medication, and like 3 months later, albuminuria decreased a little bit more, and GFR levels are sustained as previous levels. So these are like typical cases for using SGLT2 inhibitors for patients with a long duration of diabetes and CKD, and also he had heart failures. So this slide is a kind of busy slide, sorry for that. And this is a 2023 Korean Diabetes Association clinical practice guidelines for pharmacotherapy regimens. And you can see the left red box shown here. These are very similar to US or European diabetes guidelines. Depending on the comorbidity such as ASCVD or heart failure or CKD, we highly recommend SGLT2 inhibitors, which has benefits for heart failure and CKD. These are the initial options. And also when they have like ASCVD dominant, then maybe we can consider like GLP-1 in the left green boxes, or also depending on patient's situation, we can use like GLP-1 or SGLT2 inhibitors in CKD as well. So these are our clinical guidelines. And also because as previous lecturers nicely mentioned about the EMPA-Kidney data, you can see a recent publication from NEJM. The EMPA-Kidney was designed for placebo versus empagliflozin 10 milligrams per day, and the primary endpoint was like kidney disease progression or CV death. So, and they recruited more than 6,000 patients with chronic kidney disease, regardless of diabetes status. So when you look at the baseline primary kidney diagnosis from the individuals who participated in this trial, like you can see only 1/3 of patients had diabetic kidney disease, and the rest of them, they are diagnosed with non-diabetic kidney diseases. Also, I want to just briefly mention about the primary endpoints. You can see the composite CV death or kidney disease progression was decreased by 28% by the empagliflozin 10 milligrams. And also other secondary key outcomes such as all-cause hospitalization or heart failure hospitalization or all-cause deaths were decreased, but only like all-cause hospitalization was significantly decreased by 14%. Another important point from the EMPA-Kidney outcome trial is the population characteristics. Different to like credence or DAPA kidney disease, EMPA-Kidney disease participants had a little bit less severe participants. You can see the albuminuria or type 2 diabetes or ASCVD patients were slightly decreased comparing to the baseline characteristics of other clinical trials, which indicates that maybe this is more similar patients who we can see in the like real clinical settings, because a lot of endocrinologists see not severe patients who already diagnosed with ASCVD or heart failure, things like that. Also, they calculated the tertiary outcome as a like annual rate of changes in eGFR. You can see the purple line indicating the empagliflozin treated population. You can see initial dip of GFR at the like less than like 1 month, but you can see the graph turning to a little bit flat patterns, but compared to placebo, these are really, the decreasing rates are attenuated. And you can see at the 18-month, the two lines are crossing over each other. So eventually, like empagliflozin treated patients had decreased annual rate of eGFR changes, which indicates the protective effects of empagliflozin on kidney functions. What are the mechanisms of SGLT2 inhibitors? There are many researchers trying to elucidate these mechanisms. Major two effects of SGLT2 inhibitors are natriuresis and glucoseuria, and by doing that, that can lead to various pleiotropic effects. And also recently, another important point of mechanism of SGLT2 inhibitors are like fast-liking metabolic reprogramming, which can induce AMP kinase or sirtuin activation, inhibition of mTOR, which can help kidney to be more protective. So many recent reviews from Nature reviews or Circulations or Diabetes Cares, they are all many researchers are focusing on because SGLT2 inhibition can induce glucoseuria every day, like 300 calories are losing from our body that can mimic like starvation in our human body. So that can lead to like metabolic reprogramming, which can help to protect various kinds of tissues, including kidneys. The second case is a little bit focusing on young onset diabetes. You can see she was like 38 years old, female, who were diagnosed in 2012, which means that she was diagnosed with diabetes at 29 years old, quite young, and she was obese, BMI over 28. And you can see she had already hypertension, dyslipidemia, and also she had DKD, GFR 48, and also she had macroalbuminuria, more than 900. And she came to our clinic because she had poor glucose controls. When I asked her why, and she said like she failed to control diets. She ate a lot of fruits and snacks, and she was kind of in the stressful conditions. And current medication of her status was like only metformin, 1,000 milligrams, and DPP-4 inhibitors, Tradenta, 5 milligrams. And at that time, like her HbA1c was 9.4 from 7.89, which was really high. And also her fasting glucose was 250, and creatinine levels are dramatically increasing. And also other like TG levels or ACR are also aggravated. So I initially recommend her to use like GLP-1 or insulin, but she refused to use injections. So I had to choose another options. And recent, I think a very similar situation in all over the world. And you can see many broadcasting program from Korea, like he's a really famous chef. He's using a lot of sugar in his food, and a lot of young people like to eat like sugar-covered fruits, tangkuru, and also drinking a lot of beverages containing fructose. And also there is a YouTube called mukbang, which is really popular and famous in Korea and as well as all over the world. So many, like when you search mukbang in YouTube, many other countries, including like East Asian countries, they're making a lot of mukbang for increasing the numbers of people. So I used empagliflozin 10 milligram for her because she wanted to use oral medication. And then after 3 months, she had a little bit of sensation in her urinary area. So I asked her to like stop and using antifungal agent for a couple of days. And then luckily she had no symptoms after that. So I increased a little bit of empagliflozin to up to like 25 milligrams. And then after 6 months later, and also I emphasized to control her diet control. So I think not these dramatic decrease of glycemic control is due to like empagliflozin. I think she had better changes in lifestyles. So after using empagliflozin, like 9.4 to 7.8, and also GFR was improved from 48 to 53, and also albuminuria also improved. And the important point was like she decreased huge amount of weight after using empagliflozin with her improvement in lifestyle changes. So you can see from the 74 kilograms to 61 in 6 months, which was really huge improvement. And also after like recently I researched her lab from our system, and you can see after 2 years later, she's still using the same medication under control really well. Like HbA1c level is 6.0 and GFR is 51, which is stable during the 2 years, and the albuminuria went a little bit more down to like 130. So after that, I recommended her to decrease a little bit of metformin, 1,000 to 500 milligrams. So this was the like severe case of young onset diabetes, and as you can see in this busy table showing here, population of young onset diabetes in Korea is continuously increasing. So when you look at the data from 2005 to 2018, you can see the number is like 0.5 to 1, which means twofold increase in the prevalence in young onset diabetes. And also, when you look at the right panel showing here, young onset diabetes has higher prevalence of obesity as well. So you can see from 2006 to 15, the obesity prevalence is really increasing, especially in the young onset diabetes. And when you look at the left panel shown here, these are the incident rates of diabetes, which the blue lines indicating the elderly diabetes. The elderly diabetes incidence is actually going down, which means the rate of diabetes is going down in elderly. But when you look at the red panel, this is a really low flat, but the actual number is increasing in the young onset diabetes. And what's the problem in young onset diabetes? You can see these are the paper from Juliana Chan from Hong Kong, and these are the young onset diabetes who are controlled with HbA1c levels under 7%. And the pink bar indicates young onset diabetes, and green bar indicates elderly diabetes. And you can see South Korea here and bottom Taiwan here. All kinds of East Asian countries, they have similar situations. Like people who are under control, HbA1c under 7 is really low in young onset diabetes compared to the elderly diabetes. So you can see young onset diabetes has poor control of glycemia. Similar evidence was found from the Today study published in NEJM. You can see today's study is focusing on diabetes who were diagnosed in the age of adolescent. And you can see these are people who are diagnosed under 20 years. And you can see the HbA1c patterns shown here. Their HbA1c is going really fast, up to like 10% after 10 years. So they are really poor at glycemic control. And because of that, when they searched the prevalence of complications, you can see after like 12 years, people with over 80%, they had diagnosed with complications, at least one, including like AKD or neuropathy or retinopathy. So you can see from this data that usually people who are diagnosed at the earlier age, they have really poor glycemic control, which lead to the development of diabetic complications. Also, this busy table came from our Korean researchers, and like Taiwan, we also have nation insurance database set, and they researched looking at the cardiovascular risk and mortality in young onset diabetes versus old onset diabetes comparing to the general population. And you can see the red box showing here that people who are diagnosed before 40 years, they have really higher risk of all-cause death and other CV events comparing to old diagnosed diabetes. The numbers are really increasing from 1.7 to 4.2. So to conclude the second part, like clinical characteristics of young onset diabetes are like they have more aggressive disease progression, as well as likely to have various complications, and they're likely to have obese, and their beta cell functions are really rapidly decreasing, and more likely to fail on therapeutics. So because of that, so ADA guideline recommended that maybe initial combination therapy are considered for young onset diabetes. And when we consider like a combination therapies, many things can be considered. And one of the good thing for SGLT2 inhibitor is the durability. Usually like similar to TZD, like SGLT2 inhibitor can improve pathophysiology of type 2 diabetes that can increase insulin sensitivity. So this slide came from the study from Korean researchers using empagliflozin 25 milligrams versus dapagliflozin 10 milligrams, and they followed for 3 years. And those populations were like uncontrolled diabetes despite of using 3 regimens, including metformin, sulfonylurea, and DPP-4 inhibitors. And you can see the purple line showing here. These are the empagliflozin 25 milligrams versus dapagliflozin 10 milligrams, indicating that when we use like higher dose of empagliflozin, the HbA1c levels were very continuously under control for at least 3 years, indicating the durability of SGLT2 inhibitors. From our Korean Diabetes Association, we biannually producing a diabetes fact sheet to look at the current diabetes situation in Korea. And from like 2009 to 2019, so the initial prescription of anti-diabetic medication in Korean population is slightly changing. As I mentioned about the importance of combination therapies, so people are likely to have dual combination therapies or triple combination therapies for the initial prescription. And also, how about the types of anti-diabetic medications? You can see compared to the 2009 to 2019, metformin prescription prevalence is increasing, but sulfonylurea is decreasing. And also DPP-4 and SGLT2 inhibitors are also increasing. So these are the current patterns in Korea. Lastly, I'm going to share the last patient for male with 37 years. He was diagnosed with diabetes only 1 year. He had A1C levels 8.4, and he had huge body weight, like over 100 kilograms, BMI of 31. And he came to our clinic because of poor glycemic control, and also liver enzymes were elevated. And when we examine with FibroScan, which I will tell you later, we diagnosed with steatosis stage 3 and fibrosis stage 4, which has like indicating the severe hepatitis, NASH. And initially he had metformin 1000 and glimepiride, which is sulfonylurea, 2-drug regimen. And when you check insulin levels and HOMA-IR indicating the insulin resistance, which is over 2.5, indicating severe insulin resistance. And also you can see AST or ALT levels over 100, indicating the severe fatty liver disease. So I changed his regimen to increase the dose of metformin to 1500 and changing from sulfonylurea to DPP4 and empagliflozin 10 milligrams. These days, a lot of people with diabetes have diagnosed with fatty liver disease, and these days, many conferences say MASLD, metabolic dysfunction associated steatotic liver disease. And last year, our association published a fatty liver fact sheet, and comparing to the general population, they have like over 30% who have fatty liver. But when you look at prediabetes or diabetes, these fatty liver prevalence increased by 1.7-fold or 2-fold increase. So that means like more than 75% of people with diabetes have fatty liver. And among them, a lot of patients have suffered from steatohepatitis or MASH, which can lead to cirrhosis or HCC in later stage. So you know there are macrovascular and microvascular diabetic complications, but these days many researchers focusing on dementia, heart failure, cancer, and MASLD or MASH as emerging diabetes complications. So many clinics in Korea, they're using transient elastography shown here, or FibroScan to look at the MASH assessment. When we use this probe to the patients, we can indirectly measure fibrosis and steatosis. So in these cases, after like 3 months of treatment of empagliflozin, he were well tolerated. So I increased his dose to 10 to 25. And HbA1c dropped from 8.4 to 6.5. And also body weight changes, this was a little bit more. I think he did good at lifestyle changes. So 5 kilograms were gone. And also interesting point is that AST/ALT levels are going down after using empagliflozin. And after 1 year later, I examined FibroScan, which I described earlier. Initial steatosis level was 324, and fibrosis levels were 20. Like over 300 or over 10 means severe steatosis and fibrosis. But after 1 year later, like steatosis decreased a lot, and also like fibrosis went down by more than 50%, indicating the improvement of MASLD and MASH. So these are like meta-analysis recently published, and you can see the impact of SGLT inhibitors on MASH. They used MRI or FibroScan to look at the steatosis levels, and they went down. And also, they didn't do biopsy, but they used indirect measurement of fibrosis, like FIB4, and also those are improved after using SGLT inhibitors. What are the mechanisms on MASH? There are many, but usually like weight loss accompanied by the improvement in insulin resistance, also decrease in inflammatory cytokines, and also by using SGLT inhibitors that can lead to decrease the glucose loading to the liver, that can lead to the AMP kinase activation and reduce oxidative stress, that can lead to the improvement in steatosis and inflammations. Lastly, maybe we can use like combination therapy with SGLT inhibitors, because currently, recently, like FDA approved one drug for MASH, but before that, only like TZD were the effective medication for MASH. So maybe we can use like SGLT inhibitor with TZD. And this was covered by our colleague, Professor Cha, and he used like SGLT inhibitors for people with already using pioglitazone and look at the changes in liver status. And this was the randomized control trial for 6 months. And after using 6 months, body weight change decreased after using SGLT inhibitors, and also visceral fat decreased, and also like steatosis levels went down after using SGLT inhibitors combination with pioglitazone. So to conclude, like SGLT2 inhibitor has many effects, especially focusing on the improvement in pathophysiology targeted mechanism. And also I shared 3 cases who had like chronic kidney disease and heart failure for elderly population, elderly ages, and also people who have diagnosed with young ages, and also people who have diagnosed with muscle D or MASH. So I think those are the like options for using SGLT2 inhibitors who can respond well with SGLT2 inhibitors. And lastly, I like to share our Korean Diabetes Association scientific meeting, which will be held in Seoul in October. So please welcome join to share your clinical experience and researches with Korean participants. Thank you for your attention.